about a year ago. But I bet most of you have forgotten what I said back then. So I'll give you kind of a refresher course. This is such a common disease all over the United States. So, as we all know, there's different types of diabetes. There's three main divisions. First one is type 1, type 2, and then the gestational diabetes. Gestational diabetes usually means that a person is otherwise normal and only happens in females, but you become diabetic during the pregnancy. So some of the hormones which are released from the placenta for the well-being of the fetus, they usually cause resistance to the insulin, and during the pregnancy, women will develop diabetes. I don't think we have to deal with that too much in this facility. The other one is type 1 diabetes. The type 1 diabetes usually, well actually, let me back off. We may have to deal with that in this facility as your employees, yeah. So because I do see that. So even our employees too, in the office, you always see someone. So the gestational diabetes, let me just say a couple of words about that. It's definitely important. If a person has gestational diabetes, they are at a much higher chance of developing diabetes in the future. So if any of you ladies was ever told that during the pregnancy, you need to make sure that you're getting a blood test done once a year to make sure that you're not developing diabetes. Now, the other important thing about gestational diabetes is the children of the women who were gestational diabetic, those children, they themselves are at a risk of developing diabetes. So if they are overweight, then they have to be started to be testing for diabetes at the age of 25. So, yeah, so anyway, so that's the interesting. And of course, the gestational diabetes is extremely harmful for the fetus if it's not controlled properly. Those babies are usually born bigger because they have a lot of the sugars are high in the female. That sugar gets transferred into the fetus. The fetus thinks that he's getting a lot of sugar, and now he starts making a lot of insulin, and he's normal. So since he makes a lot of insulin, that insulin causes the growth of his liver, organs, and he turns out to be a bigger sized baby. So a lot of them, they have to be C-section, and of course there's a lot of other complications. And of course, once they're born, now there's no sugar. So guess what happens? Now, since they have a lot of insulin, they become hypoglycemic, and they can even develop seizures. So sometimes, you have to start giving them IV glucose in order to maintain, in order to counteract that high insulin which they've developed during the pregnancy. So anyway, the type 2 diabetes is probably, as you can see on this graph, is the most commonest type of diabetes. It usually happens after the age of 40. It's got a very strong genetical component. So most of these people, they will have some type of family member who is already diagnosed with diabetes. The defect in type 2 diabetes is that you're making insulin. Insulin is made in the pancreas. We eat food. Food gets absorbed into the bloodstreams in the form of glucose. Some of the food gets absorbed in the form of the glucose. And what happens is, in order to get this glucose into the right places, into the muscles, into the different cells of the body, you have to have insulin. So the insulin is released by a gland inside the body called pancreas, and that insulin helps move the sugar out of your blood into the tissues. So if somebody doesn't have enough insulin, or doesn't have any insulin at all, then what's going to happen is the sugar which got absorbed and is floating around in the bloodstreams is not going to be able to move into the muscles or the tissues or the liver. So that's the whole problem. So now these people, they will have high levels of sugar floating around in their blood. So what's the defect in type 2 diabetes? They do have insulin. They just don't have enough insulin. So they have a little bit less than what is needed, depending on how severe they are. And the other major problem is they are usually, the insulin that they have doesn't work as good. So their body is resistant to the insulin. So their fat cells, their muscle cells, they don't respond too well to the insulin which is floating around. Most of these people, they're overweight. And if they lose about 7 to 10% of the body weight, that actually makes a big difference in controlling their sugar. So in type 2 diabetes, it's much more important that a person tries to lose weight and eats healthier. The type 1 diabetes, which is not that common, thank God, 10 or 12% of diabetes in the United States, that's usually you're born or later on during your life, early ages, as a teenager or even before that, you will develop a defect where your pancreas stops making insulin. So the cells in the pancreas, which are supposed to make insulin, get damaged. Now, we don't know why they get damaged, but we think that it happens in an autoimmune phenomena. And what that means is that somehow your body thinks that the pancreatic cells which make insulin are not your cells. So it tries to fight them and actually ends up killing most of those cells in the pancreas. Why does that happen? Again, we don't really know all the details, but some people think it's due to the viral infection, some people think it's environmental factors or whatever it could be. But anyway, the pancreatic cells which make insulin are destroyed completely, so you have no insulin. Now this type of diabetes is lethal. If you don't take care of it, you will not be able to live. Most of these people, they end up at the hospital in the beginning, and then somebody does a sugar test on them, and they figure out they're diabetic. Usually these people, they look thin, they don't look overweight, and they're much, much younger. So the age that will start around 10, 11, 12, into the 20s. Let's get out of this, and let's look at the definition of diabetes, the first slide there. So this is how the American Diabetic Association describes diabetes. So there's 3 different criteria to diagnose the diabetes. The first one is a fasting sugar of 126. Fasting usually would mean don't eat anything after midnight, and in the morning after you had a glass of water, get the blood test done. So if you get a sugar of more than 126 on 2 different occasions, that's considered diabetes. We always try to make sure people are not on steroids. Sometimes when they're getting steroids for some reason, the sugar can be high, but that's why they say 2 different occasions. The other way to diagnose diabetes is anytime. Anytime you get a random sugar test done, and the sugar comes up to be more than 200, and if the person has appropriate symptoms to go with it, they have diabetes. The third one is, and when I say that, the other way to one other way to do that also is by doing something called a 2-hour glucose tolerance test. So what happens is, you bring in a patient, he's fasting, you give them 75 grams of sugary liquid to drink, and then you get a blood test done in 1 hour, you get another blood test done in another hour. So basically over 1 hour and 2 hours. And any one of those, if it's more than 200, that's diabetes. The third criteria is the A1C. The A1C, so the A1C, what it is we have red cells floating around in the body, and the job of the red cells is what? To carry oxygen. So the hemoglobin inside the red cells will attach, some of the sugar in the bloodstreams will attach to the hemoglobin. So what you can do is, you can look at somebody's hemoglobin, analyze it, and see what percentage of that hemoglobin has got the sugar attached to it. So if somebody has 6.5, that number is 6.5%. So if somebody has 6.5% of their hemoglobin which has got sugar attached to it, that's a definition of diabetes. to be technical, that also has to be on 2 separate occasions. So that's a basic definition. Let's get out of here. What are the symptoms? The middle one. So the symptoms of diabetes, as we can guess, I always like to think what the problem is. And the problem is what? High sugar. So what's going to happen if you have a high sugar in your bloodstreams? Well, the blood is usually filtered by kidneys all the time, constantly. Our kidneys are always filtering the blood and removing the waste products. And these waste products, they show up in your urine. So there is a system in the kidneys where the sugar, which gets filtered in the bloodstreams, gets sucked back in, because we don't want to be losing the sugar. But if the sugar is more than 180 in the bloodstreams, if the number of the glucose is more than 180, the kidneys, they get overwhelmed. So they will start not being able to absorb the sugars once it's more than 180. So what's going to happen now? You're going to lose some of the sugar in your urine. So everybody goes to high school, they learn about osmosis. Osmosis is where there's some type of chemical in a fluid, and it has the ability to suck the fluid with it. That's how the plants, they get their water to go from the roots all the way to the top. You know, of course, gravity is working against it. It doesn't want the fluid to go up, but they use osmosis, and that's how they suck up the fluid to go to the top. So the same concept is with the glucose. Glucose is considered an osmotically active chemical. So it means it has the ability to suck water or bring water along with it wherever it's going to go. So now, if you're going to have a lot of sugar which is being leaked into your urine, what's this sugar going to do? This glucose is going to also bring along water with it. Now, where's the water going to come from? It's going to come from your blood. So one of the things which will happen in diabetics, they will say they have to urinate a lot. So they're just peeing all the time, peeing a lot. Now, if you're going to be peeing a lot, what else is going to happen? You're going to get thirsty. So now you're going to be drinking a lot. So they're drinking a lot, peeing a lot. So that's the symptoms of high sugar. Now, what is sugar? Sugar is calories. We're all trying to avoid sugar. We're all trying to go on a low sugar diet. Now, if you're going to lose sugar, what's going to happen? You're going to lose energy. If you're going to lose energy, you're going to lose weight. So diabetics are losing sugar, peeing a lot, drinking a lot, and what? Losing weight. Now, once that happens, you get dehydrated, of course. And of course, with the high sugar, it also swells up your brain a little bit. So these people, they feel tired all the time. The lens inside the eyes is actually made out of fluid. There's a lot of fluid inside the lens in the eyes. So when the sugar is high, the sugar inside the lens is high. And when the sugar inside the lens is high, again, it brings water into the lens and it thickens the lens. So what happens is you start seeing blurred. So that's why they will have blurred vision. High sugars also prevent the white cells, or the cells which heal cuts and bruises. They prevent these cells from working properly. So a lot of these people, when they have cuts and bruises, they will notice that they're not healing that well. Also, a lot of them get unnecessary infections like folliculitis, or they'll get carbuncles or abscesses unnecessarily, out of the blue. And that's also because in a normal person, the body will normally fight off these infections, but in diabetics, it has difficulty fighting off these infections. Did I miss anything? Okay, we can get out of this. And feeling hungry all the time too. So even though you're losing weight, you're feeling hungry. And the only other condition that I know that happens in is hyperthyroidism. So if somebody's got a very overactive thyroid, they feel hungry and they're losing weight at the same time. So let's go to folder 2. So let's look at that. Pause it. So these are kind of risk factors for being a diabetic. So as I said, for type 2 diabetes, age over, some of them are non-modifiable. That means you can't do anything about it. And the modifiable ones, you have some kind of control over them. So if you have a family history of diabetes, of course you can't do anything about that. Age over 45, you can't stop getting older. Race and ethnicity. So usually the African American population is more prone to diabetes. In their race, they have a higher incidence of diabetes. And then, I already told you, if you have a history of gestational diabetes, and as a matter of fact, if you're a kid born to a mother who has history of gestational diabetes. And then the things that are under our control, physical inactivity, that will make you prone to diabetes. If you have a high body fat content, even high blood pressure predisposes people to diabetes, and high cholesterol too. Get out of this. So what are the complications? Why do we worry about diabetes too much? Remember I said, the high sugar which you have in the bloodstreams can actually damage the lining of the blood vessels. So our whole body is based upon plumbing. There is great plumbing in the body which gets blood to every place. So you have small blood vessels and you have large blood vessels in the body. So now the diabetes, the high sugars in the bloodstreams will affect all of these. But it usually affects the smaller blood vessels a lot more than it affects the bigger blood vessels. So where do we have the small blood vessels in our body? Well, we have them in our eyes, and we have tiny blood vessels in the kidneys, and then all the nerve cells in the body, in the legs and everywhere else, they need blood too. So they have tiny blood vessels which are supplying the blood to the nerves. So what do you get? You get damage to the eyes, but luckily the eye doctors can usually, so every diabetic patient needs to be evaluated at least once a year by an ophthalmologist. And what do? They dilate your eyes and they look at the back of your eyes and see if you've got some of this damage from the diabetes. And if you do, they can actually fix it. Of course, you still have to fix your sugar, but they can fix that damage and prevent it from getting worse. The kidneys the kidney itself has very, very small blood vessels which are used in the filtration, so you can get kidney damage from that. I believe if you go to the dialysis center and you try to find out, how most of the people, why did they ended up getting there, usually you're going to find out the cause is diabetes. And the second most commonest cause for damaging the kidneys in the long run is high blood pressure, uncontrolled high blood pressure. So that's the second cause. I think the third one is polycystic, but we don't need to worry about that. It's less common. And then, of course, neuropathy. So neuropathy means the blood vessels which are supposed to be supplying the nerves, if they get damaged, you're going to get the nerve damage. So most of the diabetics, they will have difficulty feeling their toes. It will always start with toes. If somebody is numb in hands and the feet are fine, it's not from diabetes, it's from something else. So it will always start from the nerves which are further away from your body. So it's going to come in from the legs, and then of course later on it can affect your hands too once it's come up to about here. The big blood vessels which get affected by diabetes are the ones in the brain, and that's how that predisposes you to strokes. And then of course in the heart attacks. The big blood vessels which supply the heart itself, the coronary arteries, you will get damage to those, and that can lead to heart disease. And then we all see diabetic feet. We all see people with ulcers in the foot which are not healing. We also see amputations of the toes and all that. So small blood vessels in the toes and the feet can get affected. And of course that leads to multiple problems. It leads to problems with not being able to heal, with the neuropathy, and then of course ischemia. So these are the complications related to high sugar, which has been running for a long time. If somebody was to ask me a question, what's the first thing that I would see in somebody who's got diabetes? Which one of these would happen the first? And it's usually the eyes. So we have had people who went to the doctor because they were seeing blurred vision. They haven't seen a doctor ever. They go to an eye doctor, and the eye doctor looks inside the eyes and tells them that they have diabetes, and then the eye doctor sends that patient to us to get checked out. So that's the one that you're going to see first getting damaged. You can get out of this. So number 3. This one. Let's look at the easy one first. The other one. Yep. So how do you treat it? Well, yeah. So what happened is, this is probably the most important thing. I was doing residency. I was in my residency, and there was a very good endocrinologist there who was working with us. And I think in my 3rd year, I got a chance to do a rotation with him. So basically, you work with him for a whole month, and all you do is you just see diabetics. So what he told me was that the first day that I went there, he said, you know, I worked with you, I know you could, you're going to figure out how to take care of these diabetic patients, you'll know which medication to give, but what I want you to do is, I want to show you after this month that you worked with me, and I want you to believe in something. And he said that once you're with me for a month, you're going to start believing it, you know, you're going to start seeing it, and that's when you will believe it. And the belief, and the thing that he proved to me, which I was very convinced at the end of the month, was we had 2 types of people who came to his office. There were ones who would come around, you know, 40, 50-year-old, he's lost a leg. You would ask them, what's your sugar? Well, it's running around 300. I think it's okay, it's doing all right. You know, they've had a couple of heart attacks, they've had a bypass, some of them are on dialysis. And whenever you would ask them what their sugar is or something, and they will not be able to tell you. You know, or they will tell you a little bit, a couple of scribbles on the paper, and you know, so how many units of insulin are you taking, and they kind of, sometime I do this, sometime I do this. And then we have these other type of people. And these people, when they will come to you, they will be in the 70s, and they will have a book with them, and they will have everything written, obsessive compulsive. They have their sugar, they have to do, and doc, my A1C is this and that, you know, they will know what they're doing. The point was, they had the same disease, but there were people who took care of it really well. Their feet were fine, their eyes were great, and so what he wanted me to believe in was that you have to have a strong belief that if you help people and they're willing to help themselves, you will actually make a difference in their lives. And the ones that, you know, even though it's the same doctor, same endocrinologist who's trying to take care of different people, but the ones that were not listening to him and the ones who were not following what they're supposed to be doing, they had a lot of damage from diabetes. You know, they were on wheelchairs, or they couldn't see no longer, or some of them just have to go to dialysis, you know, 3 times, 4 times a week. So just lots and lots of inconvenience. And of course, those ones, they had a lot of hospital admissions also. So basically, a lot of burden to the government, to the society, just because of not being able to take care of themselves. So anyway, and of course people have different reasons why they cannot take care of themselves, and, you know, so it's hard to judge that. But the only point I'm trying to make is, if you do a good job with taking care of it, it will improve your survival, it will prevent complications, so it works. So taking good care of the sugar will actually make a difference. So yes, fruits and vegetables, somebody said. So it's not just that, you know, weight loss, exercise, and then you can consume protein diet and fat diet actually without worrying too much that you will affect your sugar. And some of the fruits are actually bad too, like mangoes and dates, and so you can't just have all the fruits. But that's a whole different topic to talk about diet and diabetes. And what we do is, even we don't have time in the office. So sometimes when we see somebody who's brand new diabetic, we will usually refer them to a nutritionist. So the nutritionist, what they want to do is they want to sit down with them and, you know, spend an hour or so just talking about what kind of foods they eat, where do they shop from. There's tons of things to talk about. But yeah, eating the right food will definitely make a difference to a certain extent. So we can get out of the easy slide. Let's go to the tough one. Yes, this is it. So then, the medications. So what type of medications do they use for diabetes? Remember we said that in some people, the type 1 diabetics, we have no insulin. So if you don't have any insulin, the way to fix that problem is to give them insulin. So that is luckily available nowadays. Initially they used to make it out of pork, the pig insulin, and that was, once in a while people would get reactions to it and allergies and all that. But now the human insulin is available. Although, I don't know if you guys are aware, there's a big monopoly on that, the pricing of the insulin. It should be dirt cheap, but somehow, I don't know if some of you are using it, it's very expensive. And there is a flaw, there's a flaw in the American system on how it allows people to patent the drugs. So what they end up doing is, you see, because once the drug is supposed to lose its patent, then anybody can make it. But what they end up doing is they end up changing the structure of the insulin a little bit, and they never lose patent on it. So that's the reason the two companies, but I think the Congress is looking into it, because it's ridiculous. The prices of these insulin, patients will come to me and they will say, it's very expensive, and I just wouldn't believe it, because I said, how could insulin be expensive? It's been around since, 1940s and 30s or whatever, but it's crazy expensive. Anyway, the cheapest version which is available is from the Walmart. It's called Rely On. So Rely On is one of the cheapest versions, and the government has made it available, that it's available over the counter. So you do not even need a prescription for it. And the reason for that is because the type 1 diabetics, they can die if they do not get insulin. So in order for it to be easier for them to get access to it, the government at one time changed the rules, so it's available over the counter. But that's the cheapest one. It's available in 70/30, and it's available in long-acting format, NPH, and it's available in short-acting format too. So the type 1 diabetics, they can't live without insulin. You got to give them insulin. The type 2 diabetics, you can give them medication to increase their insulin, because remember, they do have a pancreas and it's working okay. It just doesn't produce enough insulin which is required, and the insulin that it produces is not working properly on the tissues, so the tissues have resistance to the insulin. Now, to improve the resistance of the tissues to the insulin, we use medications like metformin. So metformin is a good old drug which has been around forever, dirt cheap now. I think it's on the free list and on the Publix. So that one helps you lose weight and improves the sensitivity of the body to the insulin. The other medications which let the pancreas make more insulin, one of the categories is called sulfonylureas. Now the sulfonylureas listed right here, there's a bunch of them, but I think you just have to remember one of them or two of them. So we only use the Amaryl, which is the glimepiride, and we also use the glipizide, which is the glucotrol. So important thing to remember, you shouldn't have any patient here in this facility on glyburide. So this was who's the pharmacist here? The pharmacist? I'm not here today, okay. Yeah, they should automatically be picking up and stopping everybody who's taking glyburide and asking it to be substituted to the glipizide or glimepiride. I used to use glyburide myself when I came here, but they issued a report where they said that it causes a lot more hypoglycemic episodes, which of course lead to hospital admissions and all that, compared to the rest of them. Now, insulin comes in different flavors. So the insulin comes in different flavors. There's a rapid-acting insulin, and the trade name or the factory name, I think it's better to remember these by the trade names because they're popular that way, is Novolog, Humalog, and Apidra. So what's the difference between Novolog and Humalog? Actually, there's no difference. One of them says they're better than the other, others say they're better than the other, but it's two different companies, the Novolin company and then the Humalin company. So these are two different companies which make pretty much exactly similar insulin to each other. So Novolog and Humalog, they're pretty much the same, very, very fast acting, Apidra is still quite expensive. So all these three, they're still quite expensive. And then what you have is you have the regular insulin. So the regular insulin is available, again, from the same companies, Humulin and Novolin, and that's cheaper compared to those ones. I have never really found any practical difference between the regular insulin and those expensive ones. So if you have some people who are using those expensive insulins and they're not happy with the price, they can always be switched over to the regular insulin. I think the onset of action, the difference is only about 10 minutes. It doesn't make a big difference in practical life. Then you have the medium-acting insulin, and that is the NPH insulin. Again, same companies, the Humulin and the Novolin, they make that insulin. And we all know about the Lantus insulin and the Levomir. Again, they're very similar to each other. There aren't any differences in practical terms. And this is called the long-acting insulin. So basically it stays around in your body for 24 hours a day. There's another one, Toujeo, our endocrinologist uses it. I've never used it. It's an ultra-long insulin. Stays in the body for 36 hours or longer. Then we've got the new drugs called, there's two of them, the GLP receptor agonists and the DPP inhibitors. Fancy names, but what they generally mean is, so what happened is, somebody did an experiment, to make it simple, and what he did was, supposedly, just to make it easy for the numbers, they gave somebody 100 grams of sugar through the IV. And then what they did was, they analyzed the amount of the insulin which was released in that person for 100 grams of sugar. And then what they did was, the same person, they take them and they fed them 100 grams of sugar. So exactly the same amount of glucose. And then they followed his insulin, or her insulin, to see how high they got. How high does the insulin go that way? And they found out that there was a big difference. So a person who you gave 100 grams of glucose through IV didn't have such a rise in their insulin as a person who actually swallowed 100 grams of sugar. And said, why does that happen? So they started analyzing more stuff, and they found out that there are some hormones which are released from the gut. And these hormones, they actually have a duplicate or extra effect on the pancreas to release the insulin. And that's how they discovered these drugs. And those drugs now, I think most of you will know, the GLP receptor agonists, don't go with the fancy names, just go with the fact that they work somehow on the hormones in the gut. And they are, where is it? Right there. So it's Baidia and then Victoza. So those were the two initial drugs which came out, and basically they mimic, or they act like those hormones from the gut. So when a person is taking those shots, unfortunately there's no oral version of that because the stomach disintegrates that particular chemical. So you have to take it in a shot format. So what happens is these hormones are like the hormones which would be released normally from the gut to help release more insulin. So initially it was Baidia and Victoza, and if you just want some extra knowledge, they came up with the longer acting ones, and I think that Trulicity is still on the TV. I don't watch much TV, but last time I saw a lot of ads of that. And then Bidurian. So Bidurian and Trulicity, they're very similar to Baidia and Victoza, except that they are longer acting. So you can just take a shot, every 2 weeks or so, or once a week, and it'll give you the same effect as taking a shot every day. The advantage of these drugs is they do slow down the emptying of the stomach, and what they do is they will help you lose weight. So there's good evidence that people will lose, significant amount of weight. Then there is another class of drugs, because you hear these names on the TV, that's why I just want to explain to you, the Onglyza and the Januvia or Tradjenta. So all these ones fall under a category called DPP-4 inhibitors. So remember how I was talking about the hormones which are released from the gut when you swallow glucose and help increase the amount of the insulin? Those hormones then get destroyed inside the blood, inside the bloodstreams. So these drugs, they don't let those hormones get destroyed inside the bloodstreams. So that leads to higher amounts of insulin in the body. All these drugs, since they are hormonal, they do have side effects on the pancreas. So sometimes people can get pancreatitis from that. So that's the only major problem with them. And the other problem is nausea or vomiting. There's one other class of drugs which used to be very popular. I believe Avendia is not available anymore. Actos is still available. But these drugs, they work on the muscles and the fat cells, and they improve the way the insulin is, they improve the sensitivity of the insulin, just like metformin used to do. So they were pretty good. We still use them somehow, but not that often, because the problem with these drugs is they cause fluid retention. So people will usually get edema, or people who have congestive heart failure, they cannot use them properly. Do you have any questions on the drugs? Because that's what you guys see here. You know, and sometimes you wonder, what does this drug do? Or how does it work? We can get out there. So go to folder 4. Let's skip that one, because it's very similar. So the first one. Yeah. So this is basically a, if you're giving insulin to people, you should always know what you're giving and how long it's going to last in the system, or how is it supposed to work. And I've got another slide to kind of summarize that. But the rapid-acting insulin right there starts working within about an hour or so, and it peaks almost at about, I can't see it from here, but almost at about half an hour, about an hour. And then you have the regular insulin, which is a short-acting insulin in orange, I believe, and that you can see just peaks at about 2.5 hours. So there's not a huge difference between that and the other one as far as the timeline is concerned. That's why I try to save people price and just go with the regular insulin. And then we have the NPH insulin, which is the intermediate acting insulin, which usually peaks in your blood. So what we're saying is you give a shot, and then you look at the levels of this insulin, and then you find out when does it peak. How long does it take for it to get at a height? And you can see that the NPH insulin usually peaks in about 4 to 6 hours. And then of course you got the long-acting insulin, which never quite peaks. It kind of stays inside your bloodstreams once you've given it. And the important thing to remember about the long-acting insulin is, if somebody's sugar was 400 and you ended up trying to treat it with the long-acting insulin, it's going to work after 12 hours. So that's why if somebody's sugar is very high, based on the sliding scale, somebody will tell you to give them regular insulin or the short-acting insulin rapidly, and that will hopefully within an hour or so bring their sugar down. So let's get out of this. And the last slide I got, this one, see if you can enlarge it a little. No, it's right there. An arrow there. Oh, no. Okay.
Grayed out.
So this is probably the most important slide to understand. And what it does is, a lot of the patients that we see, they don't really understand how these insulins work. So what's the most commonly used insulin around in the country is going to be some type of version of 70-30, either a 75-25 or 70-30. And it's very important that a person knows how this works, before they use it. And of course, another important thing about it is, you won't be able to manipulate your insulin based upon your sugars when you don't know how it's working. And here's how it works. So supposingly somebody wakes up at breakfast, and he does his sugar at the breakfast, and he says, my sugar is high, doc. It's running 200. And what does he do instantaneously? He thinks the way to solve the problem is to increase the amount of the insulin at breakfast, because that would kind of make sense to you. Well, I woke up, my sugar is 250, what should I do? I think I should take more insulin. Well, the problem with that is that morning sugar has got nothing to do with the insulin that you're going to use at this time. It has everything to do with the shot that you took at supper time. Because at supper time at night when you're eating at around 6 o'clock, what did you do? You took a shot at that time of 70-30. And the 70-30 has got two insulins in it, the short-acting one and the long-acting one. So as soon as you eat your food at supper, the short-acting one is going to take care of your sugar, which goes up after the supper, maybe around up till 10 o'clock at night. So it peaks around, it'll take care of the sugar which would have gone up from supper at 10 o'clock at night, the short-acting version. But the long-acting version stays in your system overnight and is actually responsible for what sugar you wake up in the morning with. So the way I would solve that problem is if somebody's sugar was high in the morning, I wouldn't tell them to just go ahead and increase morning dose. I'll figure out what I'm doing wrong in the evening. Because that's how they got the high sugar in the morning to begin with. Something which they didn't do right in the evening. Usually the answer is they had a pecan pie or some kind of... so if you look at the morning sugars and they're usually running okay, but then there's couple of bumps there, you know this guy did something wrong. And you say, what did you have that day? And they will say, yeah, we were out and I just decided to have a dessert. So, well, if you decided to have a dessert, one option would have been that day at supper, take more insulin. And that would have taken care of your morning sugars next day. So, so if you are checking your lunch sugar at lunchtime, and lunch sugars are coming back high, that means the breakfast shot that you're taking, the 30 component in the insulin is not enough to take care of your lunch sugar. So that 30 component, or the short-acting component, needs to be increased. Now, supposedly you check your sugar at supper, and the sugar is high. That actually means that the insulin you took at the breakfast, the 30 component, the green one which is carrying over, that's not enough there. So that means you need to increase the 70 component in your morning shot. Does it make sense? Kind of. But that's the whole, as far as the insulin is concerned, and you take care of insulin in diabetics, that's in a short format, that's the secret slide, which shows you which shot does what to which sugar.
So if they're dropping first thing in the morning, that means we're giving them too much at supper?
That means they're getting too much at supper, but which part? You see, remember there's two parts. There's a short-acting insulin and there's a long-acting insulin. So if they're dropping at breakfast, it means they got too much of the long-acting one. Now, how can I solve the problem? What I need to do? If you tell me what their sugar was before bedtime. See, if the bedtime sugar was high, and then the morning was also high, it means they're not getting enough long-acting insulin at supper, and they're not getting enough short-acting insulin at supper. So how do you solve that problem? You just raise overall the amount of insulin. You can raise both of them. But if the morning sugar is, what did you say it was low?
Low.
Okay. If the morning sugar is low, did I say it the other way? So if the morning sugar was low, it means they got too much of the long-acting at supper.
Right.
That's how they got into the low problem. But supposedly they got that low, but at bedtime the sugar is high. So that means you're not giving them enough of the short-acting, but you're giving them too much of the long-acting. So because remember, you have the ability to mix them together. You can take the long-acting, the MPH, and mix it with the short-acting. Usually we go with 70-30 or 75-25 because that's kind of the right amount which will take care of people. But some people, when they bring the numbers back to you, you can't take care of them with 70-30s, with a fixed amount. So those ones you have to change it yourself or move to 50-50. They have the 50-50 available too. But you will never be able to understand it if you don't know